So during lunch, I threw out about half my slides to avoid duplication. And after following Kashava, I've decided I'm just going to go totally with my own opinion because he did a graduate level review of cardiopulmonary bypass and different options. I'm heavily conflicted, which I'm proud of. And what I'll tell you is all those conflicts kind of glum together, and I consider myself neutral. How do I get this thing to go forward? Okay. So let's assume that you have your typical situation where you've got a VA ECMO patient, which he said most roads lead to VA, and you've got a main femoral artery cannulation, and the patient's still hypoxic and hypotensive. So now you got to start going through what's wrong. Well, as you've heard, the left ventricle can get overloaded during VA ECMO, and white lung is common in patients on VA ECMO. It develops rapidly, it progresses. If you go to higher ECMO flow to try to crank up the flow to get better oxygen delivery, you just aggravate the situation. So you find yourself in this downward spiral of wanting to chase the PO2 in the patient, and yet you're actually overloading the left ventricle. It often causes either a longer duration of support, or you see it when you've damaged the heart. And it appears, and I say appears because the data isn't that strong, but it appears mitigated by unloading strategies. So let's go through. This is a pretty complicated chart, but it kind of a good review of what we've heard the last 2 days. First of all, a VA ECMO was designed to do oxygen delivery, but it wasn't designed to unload the left ventricle unless you're doing central VA ECMO, as you just heard the previous speaker describe. And the problem is it increases your left ventricular end-diastolic pressure, it increases your diastolic pressure, it can aggravate reperfusion injury, it increases your myocardial oxygen demand. Now, if your heart's healthy enough to eject, none of that's really a problem. But in that 30% of patients, or some literature says 10% of patients, but it's somewhere between 10 and 30%, you aggravate that left ventricle, and therefore you can back up and get pulmonary edema, and it can come on very rapidly. So ECMO was really designed to support oxygen exchange, CO2 removal, and support neonates initially, and then it's evolved to where we've used it in a number of different ways. So let's just talk about what might be easy. Well, we're worried about overloading the left ventricle. Let's just take out the old tried and true intra-aortic balloon pump. You've heard here today, it does some stuff. I mean, it helps. It's not fabulous, it's not complete support, but it unloads and augments coronary perfusion. So let's just see how that would suit us a little bit. This clicker's not working. Okay, so what's it do? Well, you see the check marks. There's one little check mark to where you can unload a little bitty bit, and you can augment the diastolic pressure, and you may increase the coronary perfusion some, and so that's good. And you feel good about it, especially when it works, right? Because we heard today in that review of intra-aortic balloon pumps, when they work, it's Yahoo, and when they don't work, it just doesn't work. So that's the same thing when you're on ECMO. Now let's talk about these axial flow pumps. I know Houston loves them. Y'all developed them here, and everybody's drank the Kool-Aid, but we don't use them that much, and we certainly don't use them with ECMO, especially when the administrators get a hold of us. But nevertheless, they do work. And as you can see, they do unload the left ventricle. They do augment the diastolic pressure. They do increase the coronary perfusion. They do decrease reperfusion injury. Now we're on a roll here. I know why y'all like them. And plus, they augment the distal organ perfusion. So what could be better? Well, they're tricky to put in, and they require a big arteriotomy, and they require a huge investment on top of the ECMO. And let's talk about that tandem heart. Let's just go whole hog. Let's just put them completely on VA ECMO, vent the left heart, and let's go ahead and take advantage of every stop we can pull. Our administrators don't like these either. But at any rate, they decrease the left ventricular end-diastolic pressure. They augment the diastolic pressure of the aorta. They'll increase the coronary perfusion gradient. They'll decrease reperfusion injury. They'll support the organs. So that's pretty good, right? Yeah, but they're pretty expensive. Big arteriotomy. You have to make a wholeness septum of of large proportions that somehow have to be closed. So it's not a gimme. So let's talk about what we do in my institution. Since you've heard all the didactics, we're going to start getting biased now. Well, the point is that when you're doing groin VA ECMO, you set yourself up for what's called Harlequin syndrome. And that is where you're perfusing retrograde in the aorta, and your heart's still sitting there pumping away, trying to decompress with desaturated blood, especially when you got a whited out lung, and especially when you've got a patient that's still hypoxic. So you're literally perfusing the coronaries with hypoxic blood. So what we've come to appreciate is we listened to what you all said earlier, by the way. I heard each one of the speakers this morning, and I'm sitting there taking notes. It's all about timing. It's all about timing. It's all about timing. Do it there early. Well, that's what we do at University of Kentucky. I told you I wanted my surgeons in the OR. I don't want the surgeons running down and trying to figure out whether they're going to go to the OR or whether they're going to do a case. No, they're in the OR doing their job. The cardiologists are set up for acute MIs. They're geared that way. They keep a room available. They keep a team available. Now, I know you guys are busy here, and I heard an earlier statement that you all don't have access to cath labs. Well, that's just sad. Because if you have access to cath lab, that's what you want to do. You want to race to the cath lab, do a full assessment, and have the ability for your interventional cardiologist to pull out the stop. So that's what we do. We do a double lumen catheter in the jugular vein so that we provide oxygenated blood to the right heart. And that way, what does get ejected perfuses the coronaries and allows the heart to eject. Plus, we do veno-arterial from the groin. So we do what's called VAV. That's become quite popular as a prep for bridge to transplant because you've got control over gas exchange and flow. And as a patient improves, you can take the artery catheter out and you still have gas exchange support. So that's what we do. Quite commonly is a bridge to lung transplant, or if we have a patient that we think is going to recover with ECMO. Now, what we've also discovered is that when that doesn't work, then we have to do what we call LAVA. And a couple of speakers mentioned that earlier. They were doing it in Canada, they're doing it some in Europe, and we're doing it at UK. And that is, we do a transeptal puncture, and we pass a cannula through the septum, and we decompress the left side. Now, we don't use that as our sole drainage because then you need a really large catheter. But we traverse the septum so we can drain from both the left atrium and the right atrium. And by doing that, we can decompress the heart and provide gas exchange. John Gurley is a good buddy of mine. We work closely together. He's our interventional cardiologist. And what he does is he just shapes a Edwards catheter and puts it in through the septum, and that way we can drain the left side and the right side. And we can do it all in the cath lab right when we're doing that full assessment and deciding exactly what strategy to use. Now, what does that do for us? Well, we think it's a home run. We can decompress the left heart. We can lower the LV EDP. We can augment the aortic diastolic pressure. We can augment the coronary perfusion with oxygenated blood. And we think we can decrease the oxygen demand of the heart by providing good coronary perfusion and also be able to partially unload the left heart. Now, this is not central cannulation like you heard the previous speaker, but this is a way to decompress the left heart as well as the right heart to some degree and provide oxygenated blood at the upper body and oxygenated blood and good perfusion at the organ level. So you can see the organs get the benefit too. You increase the pressure, you tissue perfuse the distal organs, you provide oxygen delivery to the tissues, and you provide perfusion. So in conclusion, no, wait a minute, I got another slide here. What happened to that? There we go. So when you take all these talks that we've been listening to, and you kind of put them together, this is just on the internet, it hadn't come out in publication yet, but this is a meta-analysis of all the different approaches in terms of unloading the heart in cardiogenic shock, or in this case, ECMO, which is not providing adequate ventricular support. The intra-aortic balloon pump, yeah, it does something, and when it works, it works. Percutaneous left ventricular LVAD support or left ventricular venting, yeah, it provides support, especially with an Impella device. And we could also do a transeptal LA catheter, which I alluded to with the lava technique. But overall, the improvement is at a 95% confidence level that these collective strategies can work. So what's my conclusion? Well, I think that I'm happy to do easy, straightforward veno-arterial ECMO as an initial support technique. And it works 70 to 80% of the time. And during those times when it doesn't seem to be working and the left ventricle is laboring, or you start to get congestion or LV distension, or in any way see that you're not decompressing the left heart, our treatment of choice would be to put a transeptal catheter in. And that's part of our cath lab strategy of urgent evaluation and urgent cannulation. However, I'll be the first to say there is no strategy to date that has proven superiority. So when you hear these more educated cardiologists talk about trials and talk about analysis and data, it's all very entertaining to me, but we don't have that in ECMO. You have to use judgment and you have to use timing. So when I go back from this meeting, I'm going to get on my pulpit and push for earlier and earlier intervention. Because from last year's meeting was when we set up our team to where the interventional cardiologist took people and immediately evaluated them and put them on ECMO. This year, we're gonna go quicker because you all have impressed me that the earlier you get support, the better off you are, and then you don't have to talk about all the languishing and the huge cost because you will be making patients better quicker. Thank you.
As always. Great talk. I would like to start the discussion with the example you mentioned here with the VAV. And we have to differentiate between if I'm going to go for VAV because a patient had baseline lung problem, or I'm doing VAV because the guy has an only heart problem, but because of the congestion, I'm going to go to different approach. In the case you mentioned, he was a patient have lung problem, correct? That means a different approach. If I have a patient now having heart problem, and because of the congestion, I still have hypoxia, would be your approach to unload fast to get the lung decongested, or to go for VAV? Because VAV is not going to treat. It's to decongest the heart first,
right,
and then that's going to improve the lung.
Well, you've hit the nail on the head, and that's in terms of timing and the circumstances and which comes first, right? Those are the three things you mentioned. So in the case of cardiogenic origin, we would put a transeptal catheter in first. In a patient that we think is having Harlequin syndrome, to where we're not adequately perfusing the coronaries and we're augmenting the left ventricular dysfunction, we would put them on VAV. And especially if we're going to do a bridge to lung transplant. We have found that in patients, and remember, these patients that are bridge to lung transplant, they often are in extremis. We get 50% of our patients are transferred in. We're a big referral center. We're in a state that a lot of our referral sources don't have the kind of resources we have, and so we have to be responsive to patients that are late. So we're as aggressive as hell on our patients that we can get to early, but we don't have that luxury about half the time. So if we have a patient that's a bridge to lung transplant and they've got some left ventricular dysfunction, we will put them on the VAV first, and then if the left ventricular function doesn't resolve immediately, we'll do a transeptal. But we do all that as part of our aggressive evaluation in the cath lab. Ironically, I'm probably the biggest advocate of interventional cardiologist of all the cardiac surgeons in the country.
Okay, David, please go ahead.
I hear all the time surgeons love the big arterial catheters, but when you speak to the perfusionists, they oftentimes say it's actually the flow is limited by the venous inflow. Because if you go from 15, for example, a 15A to 17A, it's not somewhat bad. Sometimes my surgeons will want to have a 22 or 24 French artery, and it's just disastrous, the complication. So I try to tell them, just put a 15 or 17
Your answer is the correct answer for ECMO. Their answer is the correct answer for central cannulation when you're going to do exactly what the previous speaker said. So it depends on where you come from and what your background is and what your experience. But we learned that lesson in ECMO, and that is the venous drainage determines flow. Now, at some point, let's just go to the extreme. Let's keep making the arterial cannula smaller. What do you really do? You increase the resistance to the inflow. And then as you increase the resistance, the pressure in the circuit goes up, and you start to see a hemolysis, and you start to see shear forces on the blood, and you can get more hemolysis. Well, that's not good. As you heard Marvin say, we don't want to be tearing up the red cells and activating the platelets. But on the other hand, that's a lot easier to deal with than tearing the hell out of the femoral artery.
So if you had your choice, would you just have a kit with a 15 and a 17, or what's your magic size if you only have one arterial cannula?
That's not fair. I'm not going to answer that. Because we've learned in this conference, there is no magic size, there's no magic setup, there's no magic ECMO, and there's no magic timing. The point is, I'm going to go as quick as possible. I'm going to use my interventional cardiologist in our cath lab that's available, and we're going to get the patient under control as quickly as possible based on measured values. How's that? Because that's what you wanted.
I think you have to measure the diameter of the vessel just to prevent ischemia, and you have to. That's not the solution to have only one size catheter. It's not going to fit all. It's important to see what kind of size of the vessel you are dealing with, and to try to select the cannula based on that. And all of the interventional cardiologists
We really did play that
are
game
good at that.
a decade ago when we were all trying to avoid having to do an extra step for distal perfusion. So we kept trying to sneak with smaller and smaller arterial reinfusion cannulas. And what we learned was the right thing to do is just routinely perfuse distally. And there's always a case that you live with the rest of your life. But we had a 24-year-old girl who was jogging, delightful college, no, she was a postgrad, delightful postgrad student, flipped over in V-fib, underwent CPR in the park, raced her in, did the whole thing, resuscitated her with VA ECMO, great result, and lost her leg. So all you have to do is have one like that, and then you just go, that's crazy. Just while you're in the cath lab, put distal perfusion cannulas in and be done with it. And that's what we do now.
Just a question here.
Oh, yeah.
Sorry for the
Hard
lights.
to see with the lights in your eye.
Yes, for sure. What is exactly the principle of the unloading of the left ventricle with a balloon and the preservation of the aortic pressure? Because is it really different from just decreasing the flow of your ECMO? Because when the balloon is inflated during diastole, well, the heart doesn't see anything if the aortic valve is closed. And when you open the valve, then suddenly the balloon deflates and the heart receives the flows that you stored below the balloon. So conceptually, I don't see a very good rationale for having the balloon, which is indeed not helping so much during ECMO. The pressure for the coronary artery will be low because it is downstream the flow of the ECMO. So what is exactly the difference between just decreasing somewhat the flow of the ECMO to the same extent?
So what you ask is a really good question. And what you set up is the fact that if I have a balloon pump in place from someone coming out of the operating room, for instance, or someone who's had a balloon pump put in before intervention, I won't take it out actively while on ECMO. But I will not put in a balloon for this particular scenario. It's simply mentioned it for completeness sake. But when you actually have a patient whiting out their lungs or they're going into hypoxia and hypotension, I don't fool with the balloon, and you're right. Now, the problem is once you're hypoxic, you're not going to turn down your ECMO flow, right? Because that defeats the purpose. That makes it worse. Now you're going to be more hypotensive and more hypoxic. So your point's a good one. I don't actively use a balloon pump to bail myself out on ECMO. I either go in with the VAV or I decompress the atrium.
But back to the flow, it's not an optional to say reduce the flow. To what level you're going to reduce the flow? You're supporting the patient in cardiogenic shock, you need flow. And you cannot reduce the flow as you want, and based on the cardiac or the index you need on the patient. Sometimes you're reducing that aortic valve is not opening. that reducing the flow is not, and many patients is not going to be the case. We are trying to restore the circulation. That's why we need the flow, and that's what the advantage of ECMO in contrast to other devices. Here we have a higher flow for the patient. In multi-system organ failure, in cardiogenic shock, you need flow.
So,
The flow to the brain to the heart will be decreased during deflation of the balloon. The flow to the brain and to the heart will be decreased during the inflation of the
I'm
balloon.
not saying the balloon, but you have to I'm sorry, saying decreasing the flow is not sometimes is not an option. I'm trying to warn from that decreasing the flow and a patient needs the flow. You have to go for something different than the balloon.
I think the key question is when to enhance LV unloading, whether we're reducing the flow or using pharmacologics. I think the concept of waiting for white lung or worsening hypoxia or clinical signs of congestion or LV distension back up, I think those are late sequelae. So my bias is these patients should have a swan. You're looking at wedge, you're doing it serially, and we can talk about that. And if your wedge is starting to come up with whatever you're doing, you have to enhance LV unloading. But I'm interested in your
That's why we do it all in the cath lab. That's exactly what I'm talking about.
So what's the cutoff? A wedge starts to come up above 12, 15, 18?
No absolute number, it's just if it's going in the wrong direction.
Fair.
We keep it
Yeah.
22
Ooh.
with pulmonary artery
That's
distress.
still congestion.
Well, if you see that it's a factor, and you look to the chest X-ray, and you're looking to the echo as well, serial echo. That's not only one factor. That we have to monitor those patients closely, and you see 22. The lung is clean, and the chest X-ray is clean, and your echo is okay. You are fine.
For those of you in the room, you ought to know that the reason Dan's such an expert is we spent decades thinking that the white lung and VA ECMO was inflammatory mediators. We'd turn on the ECMO circuit, the platelets in the white and the red cells would, and the white cells would see the blood surface interaction, and immediately they'd spew everything known to man to white out the lungs. He's the one that did the mathematical modeling and made us rethink the problem in terms of left ventricular dysfunction and left ventricular overload. So all these treatments have evolved just in the last few years, largely due to his studies, right? Fair?
Thank you.
I was going to comment that on the issue you raised and the issue that was raised, we should be able to model this, bringing up the modeling thing again. The issue of sort of the intermittent effect of unloading, which occurs with a gap of a 30, 40, 50, 60 cc balloon suddenly appearing versus turning down the flow. And the issue, there are a lot of points. We're actually working with a group that of hydraulic engineers. Totally out of the box idea, working with this thing called bond graphs. We just created a bond graph model of everything. And I think it would be a very nice way to tackle that problem, because the issue is that pressure is a scalar. Flow is a vector. And looking at those different things, it really depends upon how quickly that differential effect can be translated hydraulically from where the balloon is to the coronary versus the impact of opening and ejection from the ventricle. We should be able to figure a lot of this stuff out. So I think it's a good thing for some of us modelers to take on and give us a year. Maybe we'll have a better answer, at least theoretically. Thanks.
How would you handle this in Amsterdam?
I think you have, our ECMO experience has just started 2 years, so I think you have a more larger experience, and so I cannot add actually at this moment.
Yeah, but you have fresh eyes.
Well, the concept of ECMO is something that has always, I'm troubled with all of the energetics, but I'm here surrounded by so many people who do such a great job. So I really don't, I can't add. Yeah, sorry.
Fair.
Take the last question for the sake of time.
Quick question for VA ECMO and LV unloading for both Ali and yourself. Chemical unloading. When do you pull the trigger? If all these patients are coming out with a PA catheter, do you start with chemical unloading and then move into an LV impella to unload? What are your trigger points? How do you, or does everyone on VA ECMO automatically get an LV unloading from the get-go?
No. Remember, if the left ventricle is able to eject, it'll unload itself. very similar to weaning from cardiopulmonary bypass, as you heard the first speaker say, is once you get on your payback, or in this case, once you provide circulatory support and oxygenation, 70–80% of the time the left ventricle will eject just fine. But it's in that 20% of patients, let's say, that you start to see left ventricular overload and you start to see a lung progressive whiteout. But as you heard earlier, that's a bit late. It's much better if you measure it in the cath lab while you're cannulating, and that's what we try to do. We try to be very active and detect these things fairly early. And that's when all these other strategies kick in, depending on your resources and your skill set and what your administrators are allowing you to buy as far as toys to unload the heart.